Hello everyone, nice to meet you. This is Mylin from the respiratory department. In this class, we will learn a new disease, the cold pulmonale. In Chinese, it's called 肺心病. In this class, we will learn about the introduction, clinical manifestation, auxiliary examinations, diagnosis, and treatment for the cold pulmonale. At the beginning or in the end of this class, we will have a case analysis. Now, let's look at the introduction of the cold pulmonale. Firstly, let's look at a case. It's a 56 years old man, a farmer. The main complaint of this patient is cough, sputum for 5 years, dyspnea for 2 years, and these symptoms turn worse with edema for 3 days. The past history shows the smoking for more than 20 years. During the physical examination, we can find a slight increase of the pulse and increased respiratory rate with detention of the jugular vein, sinuses, barrel chest, decreased vocal parameters, decreased breath sound, but no rales in the lungs. During the examinations of the heart, we can find the second sound in the pulmonary valve area is louder than the second sound in the aortal valve area, which shows the hypertension of the pulmonary artery. And we can also find the increased boundary of the right heart. In the lower limbs, we can find symmetrical edema in both lower limbs. And now think about this question. What's your initial diagnosis? Now, cold pulmonale is the right ventricular enlargement, including the hypertrophy and or dilatation, which secondary to the abnormal change of the thorax and lungs. From the definition, we can pick out some keywords which will present the formation of the cold pulmonale. Let's look at this picture. There are 3 circles in this picture, including the circles A, B, and C. The common portion of the area D is the cold pulmonale. And what are A, B, C? Firstly, there must be a primary pulmonary or thoracic disease for chronic or acute causes. And next, this disease will cause a pulmonary hypertension, which finally results in the enlargement of the right ventricle, including the hypertrophy and or dilatation. It's about the formation of the cold pulmonale, and also call it the pathogenesis of the cold pulmonale. And now let's look at the 3 steps of the pathogenesis of the cold pulmonale. The first step is the primary pulmonary disease or thoracic disease, including the bronchial or pulmonary disease, such as the obstructive pulmonary disease, the COPD, asthma, bronchiectasis, and so on. And another type of the bronchial or pulmonary disease is the restrictive pulmonary disease, such as the pulmonary fibrosis and other interstitial pulmonary disease. The second type of the disease is the vessel disease, such as the pulmonary embolism, and others including the thoracic disease, such as the chest deformity, spinal deformity, and so on, which can also cause a cor pulmonale. Others including the OSAS, obstructive sleep apnea hyperventilation syndrome, and so on. And all of these above disease can finally result in the pulmonary hypertension. How to confirm the pulmonary hypertension? We can do these two examinations for the patient to measure the pressures in the pulmonary artery. One is the right heart catheterization. Another one is the echocardiography. The right heart catheterization is the golden criteria for the pulmonary hypertension, but is an invasive examination, so most patients will not receive this invasive examination. And the echocardiography is a non-invasive examination. During the examinations, we will measure the mean pulmonary artery pressure, MPAP. The normal range of the MPAP is between 12 to 15 millimeter of the mercury at rest during the right heart catheterization. And once the MPAP more than 25 millimeter of the mercury at rest, or more than 30 millimeter of the mercury on exertion, we can diagnose a pulmonary hypertension by the right heart catheterization. But if we choose the echocardiography, only when the MPAP more than 50 millimeter of the mercury can confirm the pulmonary hypertension of the patient. That's the auxiliary examinations for the pulmonary hypertension. And now let's think about this question. Why did the pulmonary hypertension occur? For now, there are three mechanisms for the pulmonary hypertension. The first one is also the most popular one, is that the primary pulmonary disease or thoracic disease will cause a hypoxia firstly. In the early stage, the hypoxia can induce a vasoconstriction, which is also known as a functional change of the capillaries. And this vasoconstriction can result in the increased pressure of the pulmonary arteries. If the hypoxia exists for a long time, it can induce the hyperplasia of the endothelium, which will finally cause the structural change of the small arteries. It's called small arterial stenosis. In this condition, the increased pressure of the pulmonary artery will exist for a long time, and that is the pulmonary hypertension. This first mechanism for the pulmonary hypertension is the most popular one, and there are also other two mechanisms for the pulmonary hypertension. The second mechanism of the pulmonary hypertension is the embolism. Let's look at this picture. This picture shows the normal vascular network of the lungs. And now there is an obstruction of the pulmonary artery. It will cause the increased pressure of the upstream of the pulmonaries, including the pulmonary trunk and the right heart. So, the pulmonary embolism can directly increase the pressures of the pulmonary artery because of the obstruction. The third mechanism of the pulmonary hypertension is about the massive parenchymal damage. As the picture showing, once the patient gets an emphysema, pulmonary fibrosis, and other disease, the capillary network can be damaged, combining with the massive parenchymal damage. So, it's hard for the blood transfer from the artery to the veins, and the pressures in the artery will increase. That's the three popular mechanisms for the pulmonary hypertension. Once there is a pulmonary hypertension, it will induce the ventricular enlargement of the right heart. For example, if the pulmonary hypertension exists for a long time, there will be a hypertrophy of the right ventricle because of this chronic pulmonary hypertension. It also belongs to a structural abnormality of the right ventricle. But in the other side, if the pressures of the pulmonary artery just increase rapidly and last for a short time, it will induce a functional abnormality of the right ventricle because of the acute pulmonary hypertension. That is the dilatation of the right ventricle. In this condition, the patients usually got acute symptoms caused by this acute right heart failure. That's the pathogenesis of the core pulmonale. Firstly, with a primary pulmonary or thoracic disease. And next, this disease can induce a pulmonary hypertension. And finally, this hypertension can finally induce a ventricular enlargement of the right heart. Now, let's move to the clinical manifestation. We know that the core pulmonale is the secondary disease caused by the primary pulmonary or thoracic disease. So, the symptoms of the core pulmonale are complicated, but we can divide them into different groups. The first group of the symptoms is about the main symptoms caused by the core pulmonary directly. It's also about the pulmonary hypertension and right heart failure, including the edema. Once we find the edema exists, we need to record the characteristics of the edema. Does the edema exist in one side or both sides of the lower limbs. The location of the edema is in the lower limbs or on the face or other disease, and whether the edema is pitting or not. That's the characteristics of the edema. Another symptom is the loss of the appetite. These two symptoms are caused by the congestion of the systematic venous system. Other symptoms include chest pain, syncope, palpitation, and so on. All of these symptoms are caused by the pulmonary hypertension and right heart failure. The second group of the symptom is associated to the causes. That is the primary pulmonary or thoracic disease. For example, we know that the COPD patient can also combining with the cold pulmonale. Once the cold pulmonale is caused by the COPD, the patients usually got cough, sputum, and dyspnea, and other symptoms of the pulmonary hypertension and right heart failure. Once there is a pulmonary embolism with acute cold pulmonale, the patients are likely to get chest pain, dyspnea, hemoptysis, and other symptoms with the right heart failure. So, the second group of the symptoms is associated to the causes, and we need to identify them, which can suggest the primary pulmonary or thoracic disease for the patient. The signs can also be divided into two groups. The first one is the physical examinations of the heart, and the positive signs are caused by the pulmonary hypertension and right heart abnormalities. For the patients with pulmonary hypertension, we can find the second sound of the pulmonary wave area louder than the second sound of the arterial wave area. That is the increased sound 2 of the pulmonary wave area, or pulmonary split, during the auscultation of the heart. Once the patient with a right heart abnormality, we can find the increased pulse, and during the physical examinations of the heart, we can find the boundary of the right heart increased too. And during the auscultation, we usually can find the murmur in the tracheal speed wave area. And other signs include the distension of the jugular vein or enlargement of the liver and spleen. That's the first group of the signs which are associated to the pulmonary hypertension and right heart abnormality. The second group of the signs is associated to the primary disease, about the physical examination of the thoracic and lungs. Let's take the COPD, for example. During the physical examination, we can find the increased respiratory rate, barrel chest, vocal parameters decreasing, dullness during the percussion, and decreased breath sound. And sometimes we can also find the wheezing reels. So that's the second group of the signs. Now I leave 2 questions for you, and I hope that you can give me your answer during the question and answer session. Okay? The first question is, what's the mechanism of the murmur in the tracheal speed wave area for the patients with cor pulmonale? And the second question is that, what's the mechanism of the distension of the jugular vein and enlargement of the liver for the patients with right heart abnormality? I hope you can give me the answers during that session. Now, let's move to the auxiliary examinations. Electrocardiogram is one of the most important auxiliary examinations for the heart disease. The sequence to read the report of the electrocardiogram is from the P wave to PR interval, QRS wave, ST segment, and finally to the T wave. Now, this picture shows the figure of the electrocardiogram of one patient with the cor pulmonale. Let's look at this picture and try to find the abnormal trends in this patient. Firstly, let's look at the P wave. We can find increased P wave amplitude. Let's look at here. Each box presents 0.1 millivolt. And let's count the box of the P wave. We can find the amplitude of the P wave is nearly 2.5 of the box. That means the amplitude of the P wave is nearly 0.25 millivolt, and the normal range of the P wave is less than 0.2. So here shows the increased P wave amplitude. The second change of this electrocardiogram is about the right ventricular hypertrophic. Let's look at here. The voltage of the R wave in the V1 lead plus the voltage of the S wave in the V5 lead is more than 1.05 millivolt. So, according to this data, we can conclude a hyper voltage of the right ventricle, which shows the right ventricular hypertrophy. The third change of the electrocardiogram is about the right axis deviation. Let's look at here. In the one lead, we can find the direction of the dominant wave is downward. And in the 3 lead, we can find the direction of the dominant wave is upward. So we can conclude a right axis deviation. About the echocardiography, it's the most important examination to evaluate the structure of the heart and the function of the left heart. And we can also measure the pressures of the pulmonary artery. This picture shows the image under the ultrasound. During the echocardiography, we can find the hypertrophy of the right ventricle with or without right atrium in the patients with chronic cor pulmonale. But for the patients with acute cor pulmonale, we usually can find the dilation of the right ventricle with or without right atrium. Usually, we can find the pulmonary hypertension in this patient. And sometimes we can find the tricuspid regurgitation. And the echocardiography is the most accurate examination for the evaluation of the structure of the chambers. Later, we will learn about the radiologic examination for the cor pulmonale. We can also find some abnormal change of the structure of the heart during the radiologic examination, but we cannot confirm the structural abnormality of the chambers. So we need to remember that the echocardiography is the most accurate evaluation for the structure of the chambers. Okay. And now let's move to the radiologic examinations. Firstly, let's look at the X-ray. In normal condition, the lumps in the X-ray can be divided into 9 areas: superior, median, and inferior, lateral, median, and internal. In normal condition, the lung markings can be found in every area of the lumps, but is predominant in the median internal area. In this image, we can also find some structure. Here is the aortic lobe, and this area is for the pulmonary artery. And here shows the boundary of the left ventricle. And here shows the boundary of the right atrium. This picture shows the normal image of the chest X-ray. And now let's look at the image of X-ray for the cor pulmonale. What can we find from this X-ray? Okay, firstly, let's look at the lumps. We can find the lung markings is more than normal condition, right? And the boundary of the right atrium is increased. We can also find the enlargement of the left hilum, which present a hypertension of the pulmonary artery. Okay, let's look at another image of the X-ray for a patient with cor pulmonale. What can we find from this X-ray? Yes, we can find here. Here shows the extension of the descending pulmonary artery, which caused by the pulmonary hypertension. From this picture, we can also find here. Here shows a emphysema or a huge bully, and this patient are likely suffer from a COPD, which may be the primary disease for the core pulmonale. And now let's look at the CT scan for the core pulmonale patient. Firstly, let's look at the normal image of the CT scan. Here shows the aorta, and the yellow line shows the diameter of the aorta. Here shows the pulmonary trunk and the left pulmonary artery, the right pulmonary artery. The yellow line shows the diameter of the pulmonary trunk. In normal condition, the diameter of the aorta is wider than the diameter of the pulmonary trunk. And now let's look at the CT scan for the patients with core pulmonale. Here shows the aorta, and here shows the pulmonary trunk, and the left pulmonary artery, the right pulmonary artery. What about the diameter of these two vessels? Yes, in this image, we can find the diameter of the pulmonary trunk is wider than the diameter of the artery. So that's the image for the pulmonary hypertension in the patient with core pulmonale. Let's look at the heart in the CT scan. In normal condition, here shows the chambers of the heart. But in the patients with core pulmonale, what can we find during this CT scan? Yes, we can find here the shape of the right ventricle is abnormal. That is the enlargement of the right ventricle. BNP, the brain natriuretic peptide, is also an important examination for the heart abnormality. The BNP, which have an opposite effect to the antidiuretic hormone, ADH, is a substance secreted by brain. Once the cardiac muscle cells are strained in the acute heart failure, the nervous impulse will be transmitted to the brain. So, in this condition, the brain will secrete the BNP to order the kidneys to expel more water out of the body. So, in this condition, the preload of the heart will decrease. And that's the mechanism of the BNP. The BNP is the best marker for the heart failure for now in the serum. But we can find the increased BNP in both right heart failure and left heart failure. So we cannot conclude a right heart failure or left heart failure only according to the level of the BNP. Another important examination for this patient is the cardiac catheterization. The catheter can reach the right heart through the inferior vena cava or superior vena cava. This examination is the golden standard to measure the structure of the right heart and pulmonary arterial pressure, but it's an invasive examination, so we just do this examination for only a few special cases of the patient with the right heart disease, and that's the special examinations for the patients with pulmonale. There is another group of the examinations for this patient with pulmonale. The purpose is to search for the causes of the pulmonale. For example, if the pulmonale is caused by the COPD, we need to arrange the spirometer for this patient to confirm the diagnosis of the COPD. In this condition, we can find the ratio of the FEV1 over FVC less than 70%. We have learned this before, right? If the patient with acute pulmonale, which caused by the pulmonary embolism, in this condition, we need to arrange the D-dimer or CT pulmonary angiography for this patient to confirm the diagnosis of the pulmonary embolism. And others, lung fibrosis, ulcers, and so on. So, please pay attention to here. Once the patient is considered to be a pulmonale, we need to pay attention to the primary pulmonary or thoracic disease. In this condition, we need to arrange some necessary examinations for this primary disease according to the symptoms and signs. And that's the auxiliary examinations for these patients. Now, let's move to the diagnosis for this patient. There are 3 steps for the diagnosis of the pulmonale. Step 1, to confirm the right heart abnormality. Step 2, to confirm the primary pulmonary or thoracic disease. And finally, step 3, to search for other comorbidities. Once the patient got symptoms of the edema and loss of appetite, during the physical examinations, if we find any positive signs of the heart and gangrene or edema in lower limbs, we can suspect a right heart abnormality. In this condition, if we find other evidence of the primary pulmonary or thoracic disease, we can suspect a pulmonale. And next, we need to do some examinations for this patient to confirm the right heart abnormality. There are 2 kinds of the right heart abnormality. One is the functional abnormality. Another one is the structural abnormality. For the functional abnormality, we need to arrange BMP and sometimes the cardiac catheterization for this patient to confirm the function of the right heart. For the structural abnormality, we need to arrange echocardiography or electrocardiography for this patient to confirm the structural abnormality. If we can find any positive results during these examinations, we can conclude a right heart disease for this patient. And next, we also need to confirm the phase of the right heart abnormality in acute stage or chronic stage. The patients with acute right heart abnormality usually caused by some acute causes, such as massive pulmonary embolism, acute myocardial infarction. And the chronic right heart abnormality usually caused by some chronic causes, such as COPD, asthma, and so on. That's the step 1, to confirm the right heart abnormality firstly. And now we need to move to the step 2, to confirm the primary pulmonary disease or thoracic disease. It's the same to the auxiliary examinations. We also need to do some differential diagnosis to exclude other disease which can also cause a right heart abnormality, such as the ventricular septal defect, primary pulmonary hypertension, and right heart failure caused by many kinds of the heart disease, and so on. Step 3. Finally, we also need to search for other comorbidities, such as the enlargement of the liver, peptic ulcer, respiratory failure, and so on. That's the diagnosis for this patient with pulmonale. Now, let's move to the treatment for this patient. The approaches of the treatment for this patient is the same to the patients with other disease. We have talked about this for several times, right? Because it's useful for almost all of the patients. There are 3 parts for the treatment. Part 1, treatment for the cause. For this patient, that means the treatment for the primary pulmonary or thoracic disease. Part 2, treatment for the symptoms. That means the treatment for the pulmonary hypertension and right heart failure. Part 3, treatment for the comorbidities. Firstly, let's look at the part 1, treatment for the primary disease. For the COPD, we can provide bronchodilators, glucocorticoid, and other drug therapy for this patient to control the primary disease. And asthma, tuberculosis, pulmonary embolism, lung fibrosis, ulcers, and so on. That's the first part, treatment for the primary disease. Part 2, treatment for the pulmonary hypertension and right heart failure. For the pulmonary hypertension, there are several kinds of the drugs for this patient to decrease the pressure of the pulmonary artery. But for now, just only a few drugs can have a moderate or well effect to the pulmonary hypertension. Bosentan, sildenafil, but these two drugs are too expensive. For now, only a few patients with severe pulmonary hypertension just receive this therapy in China. Another treatment is for the right heart failure. The first one is the oxygen therapy. We just talked about the mechanism of the right heart failure before, right? The dyspnea, the long-term dyspnea, can induce the increased pressure of the pulmonary artery. So, once the patient received a long-term oxygen therapy, in some special cases, such as the severe COPD, and so on, it will decrease the risk of the right heart failure for this patient. Diuretics is a very useful drug for the patients with acute right heart failure. Sometimes the patients maybe need some other drugs for the right heart failure, such as the inotropic agents and vasodilators. But these drugs are much more useful in the patient with left heart failure. So, we usually do not use these drugs for the patient with only right heart failure, but for the patient with right and left heart failures. So, we usually provide oxygen therapy for the patients with chronic right heart failure and diuretics for the patients with acute right heart failure. That's the treatment for the symptoms. That means the treatment for the pulmonary hypertension and right heart failure. That's all for this class today. And finally, let's look at some cases. The first case is for a 56-year-old man, a farmer. His main complaint is cough and sputum for 5 years, dyspnea for 2 years, tongue worse with edema for 3 days. And others, including the past history, physical examinations, and auxiliary examinations. You have several seconds to watch these details of their case. And finally, you need to think about this question. What's your initial diagnosis for this patient? Okay, what's the initial diagnosis? First one is maybe AE-COPD. Why? This patient with a chronic cough, sputum, and dyspnea. This patient also have a history of smoking for 20 years, right? And during the physical examination, we can find the barrel chest, vocal parameters decreasing, decreased breath sound. All of these will show the suspicion of the COPD. And during the examinations, we can also find the emphysema in the X-ray. So, we need to think about the diagnosis of the AE-COPD. But we also need to confirm this diagnosis for further spirometry, right? That's the first initial diagnosis. The second diagnosis is the chronic cold pulmonale. Firstly, this patient with a suspicion of COPD, that's the primary pulmonary disease. And step 2, how about the right heart abnormality? Let's look at here. During the symptoms, we can find edema, right? And during the physical examination, we can find the pulse increased and distension of the jugular vein. P2 is louder than A2. Increased boundary of the right heart and edema in lower limbs. During the examinations, we can find the diameter of the right ventricle increasing. And this patient also got a moderate pulmonary hypertension. And the BNP is significant increased. So, this patient with a functional abnormality and structural abnormality of the right heart. So, in this condition, we can conclude the diagnosis of the chronic cold pulmonale. Here is the second case. What's the initial diagnosis for this patient? A young man, right? With a sudden chest pain dyspnea for only 1 day. That means an acute disease. During the physical examination, we can find the distension of the jugular vein, stenosis. No displacement of the trachea shows unlikeliness of the pneumothorax. And during the physical examination of the lungs, there is no positive findings. And about the heart, we can find the P2 is louder than A2. The boundary of the right heart is normal and no murmurs. Edema only in left limbs. Does it suggest a right heart failure or other disease? Okay, let's look at the auxiliary examinations. During the echocardiography, we can find the dilation of the right ventricle and severe pulmonary hypertension. The BNP also increased significantly. And during the X-ray, there is no special finding of the lumps. So, during the auxiliary examinations, we can find the structural abnormality and function abnormality of the right heart. Furthermore, we can also find the pulmonary hypertension. That means these patients are likely to suffer from a cold pulmonale, right? But what are the suspected primary disease for this patient? Let's look at here, chest pain and dyspnea. This patient also got cyanosis and edema in just one limb. Edema in a single limb usually shows not a right heart failure, but a deep venous thrombus in the affected limbs. So, what's the initial diagnosis for this patient? According to the details in the medical record, we can give out our initial diagnosis for this patient. The first one is the pulmonary embolism with the deep venous thrombus in the left lower limb. Because this patient got chest pain and dyspnea. We also find the dyspnea according to the cyanosis and edema in the lower limbs. All of these details shows the suspicion of the pulmonary embolism. The second diagnosis is acute copulmonale. Firstly, this patient may be with a primary pulmonary disease of the pulmonary embolism. This patient also got a right ventricular dilation and functional abnormality of the increased BNP and a severe pulmonary hypertension. In this condition, which examination is the most important one for this patient for the next step? That is the CTPA. Okay, let's look at this picture. This picture shows a CTPA for this patient. It's similar to a common CT, but the contrast agent is injected into the body of the patient through the veins. So, it's easy for us to identify the vessels, embolisms, lymph nodes, and other soft tissues. In this picture, we can find here shows the aorta, pulmonary trunk, left pulmonary artery, and the right pulmonary artery. Now, let's look at here. Here shows something with abnormal density in the left pulmonary artery, right? And here also shows something with abnormal density in the artery. Those are the embolisms in the left pulmonary artery. So, according to this image of the CTPA, we can conclude the diagnosis of the pulmonary embolism. And that's the two cases for this class. Okay, that's all for this class today, and thank you for your attention.